again and share. And let me just see what Ryan is saying before we. Oh, oh, okay. It sounded like it seemed like you're going to say something really interesting. So, okay. All right. So, we started talking about the parasympathetic nervous system. So those were the cholinergic receptors, and it was acetylcholine that is the neurotransmitter, and this is going to be in the same areas that we talked about before: lungs, heart, vessels, GI, GU. So we're not just completely relaxing, it's just that our priorities have changed. So at this time, the pupils constrict. There's an increase in salivation. The lungs, it's not like they constrict, but they're not relaxed. So before we had the bronchos really wide in order to allow oxygen in, and now it's just like normal. We're not making them go less, but we're not dilating them. The heart rate is down. The blood vessels, those peripheral blood vessels are relaxed, and so there's blood flow to other places in the body besides the brain, which means we can increase motility. So we can digest, and we can contract the bladder muscle so we can urinate. So if I see these are the priorities now, and if I know that the patient is on a cholinergic medication or a medication that will activate or act like the parasympathetic nervous system, what types of nursing education will I have to do? Just like we did for the sympathetic. Now, what would we say regarding the parasympathetic? Like for the pupils, we told them not to drive during the day. What would we say now?
Decreased lower heart rate and a lower blood pressure.
Yeah, so they will have a lower heart rate and a lower blood pressure. That could be just fine for them, but that might be something to monitor for sure. That's a good one, Scott. Says take your time changing position, because we know it might be a little bit more for the body to adapt. So that's a good one. What about the driving? When should they not drive or be careful driving? Right. Because at night we want to open the pupil to allow more light in, and if we can't, if the eyes are constricted, then it'll not be as safe to drive at night. And then we have this GI tract issue, so it could tend towards diarrhea instead of constipation, or it could trend towards urinary frequency. So we should just keep those things in mind, and that is what the exam is, or not exam, I take that back. The quiz is going to be about in the beginning of next class. So you'll have completed the Neuro Part 1 ATI, and we'll have uploaded your score, 85% or greater, and then when the quiz opens, it will be a matching type of thing where you would choose, is this sentence, or is this something that goes with the sympathetic nervous system or the parasympathetic nervous system? So this is the packet, or that's the portion that you would want to study to be sure that you understand the names of the receptors, the names of the neurotransmitters, what happens if that area is activated, and whether it be sympathetic or parasympathetic, and what should you tell the patient if that's the case. And it's easy to get it all confused, so try to look at it a little bit every day. Because now we will go to our next packet. talking specifically about some of the medications, just briefly, that will affect the sympathetic and parasympathetic nervous system. We've already talked about medications that block the sympathetic nervous system because that was some of our cardiovascular medications. Some of the medications that activate the sympathetic nervous system we haven't talked about yet because those are medications for respiratory issues, which will come up later. So then you'll know that you'll see this again. At least that's nice. And then we will talk a little bit about cholinergic and anticholinergic medications, which are the ones that affect the parasympathetic nervous system. So we already mentioned this. It's the alpha and beta, which are adrenergic receptors. The neurotransmitters are epinephrine and norepinephrine. The medications that stimulate the adrenergic receptors, you don't have to worry about just yet because that's the respiratory unit. So we'll talk about that in the coming weeks. But we have talked about medications that block the adrenergic receptors, alpha antagonists and beta antagonists, or alpha blockers and beta blockers. What was our alpha blocker? This is a blood pressure medication. Well, I appreciate it because at least I know you were listening, Che. Anybody got the alpha blocker? Was doxazosin. Maybe you were typing that, Scott. I'm sorry if I took away your thunder. So that's the medication that blocks alpha receptors. So labetalol is an alpha beta blocker. So partially, because that does both. So that is partially correct. Doxazosin specifically blocks alpha receptors on blood vessels to cause dilation, which decreases blood pressure. And that was what was the beta blocker or beta antagonist or adrenergic antagonist. The labetalol is half a beta blocker, but there's one that was completely.
Metoprolol?
Yes, metoprolol is the answer. Those OLOL, OLOL medicines. So those we know are blocking the sympathetic activity. So if the medication blocks the sympathetic nervous system, it's a little more similar to the parasympathetic nervous system. So these are medications that we're going to talk a little bit more about, and these are medications that affect the parasympathetic nervous system. And in this case, the neurotransmitter is acetylcholine, and the receptor is cholinergic. And if we stimulate the cholinergic receptor and act like acetylcholine, then the medication is considered cholinergic. And if we block the cholinergic receptor or block the activities of acetylcholine, then the medication is considered anticholinergic. So this is our example of a cholinergic medication that works on the parasympathetic nervous system. It's supposed to act just like acetylcholine, specifically on the bladder muscle. So we don't necessarily want it to work in the other places where the parasympathetic nervous system receptors are. It's treatment for urinary retention. So in order to understand this medication, you have to understand how the bladder works. So here's my bladder. And we have these internal and external sphincters, and then you have a big muscle on the bladder called the detrusor muscle. So the bladder itself responds to stretch. So once it gets full, a message is sent to the brain saying, you should really pee. And part of that occurs because the involuntary part of it is that the bladder muscle contracts, which pushes the urine down towards the external urethra, that external sphincter. This is the muscle that you have control over, hopefully. This is the voluntary muscle. Because once your bladder is really full and then the bladder muscle contracts, you're like, well, I gotta go to the bathroom, so you pee. If someone has urinary retention, sometimes, specifically non-obstructive urinary retention, it could be that this muscle isn't strong enough for some reason. It's not working like it's supposed to, or not responding appropriately. A lot of times it's something called a neurogenic bladder, where maybe there was damage to the nerves that are supposed to feed the bladder and it's not working anymore. So you can give bothanicol, and it should act on the receptors on the detrusor muscle. So I give this medicine that will cause the muscle to contract, causing the urine to come down to the external urethra, or the where my voluntary muscle is, so that I can go to the bathroom. Um, so the side effects will be cholinergic. That means we wanted the medicine to only work on the detrusor muscle, but we know that none of the medicines we've ever made have completely been perfect. Sometimes they touch other receptors, and the ones that we're most worried about here is if the patient already has a low heart rate, because if it happens to cause stimulation to their heart, as a parasympathetic medication, that means the heart rate will go down even lower. Or if the patient has asthma, because in the setting of asthma, we want the lungs to be able to dilate if needed. But if the patient is on a cholinergic medication, they might not be able to do that. And then they can't adapt to or respond to their asthma. So the other issue that you'll see here is it says non-obstructive urinary retention. So people can have urinary retention because there's a problem with the nerves that go into the muscle. But some people have urinary retention because they have a big old prostate right here. So it's not that the muscle isn't working, it's that the urine can't get through. So I don't need to overstimulate their muscle. It's not going to help them pass urine. In fact, it'll make them feel really uncomfortable. So I only give it for non-obstructive urinary retention. And because it has some parasympathetic nervous system activity, people who have a history of asthma or people who have lower heart rate, I have to be cautious. And if the person got too much of it, I can give them an anticholinergic as a reversal, just like I gave anti-opioid receptor and opioid antagonist in order to reverse opioids. I could do the same here. And those are our next medications. Oh, I thought I took this slide out. Cross this slide out because it's a mistake, which I thought I took out, so I apologize for that. The anticholinergic medication we'll talk about is atropine. So this is anticholinergic, so you'll see it's the reversal for a cholinergic medication because it'll block cholinergic receptors. And atropine is a medication that's often given IV, although you might have seen it given, depends on your work situation. It is sometimes given in hospice care because it dries up secretions. But in this situation, we're talking about it as an emergency medication if someone has a cholinergic crisis or cholinergic poisoning. There are plant poisons that can trigger a cholinergic crisis in a human being, which would mean they would need atropine. Or if they were overtreated or took too many cholinergic medications, like we just talked about, you could give atropine as an antidote. Or atropine is also an IV medication that's used for symptomatic bradycardia. So not just that the heart rate is slow, that the person has symptoms because their heart rate is slow. What kind of symptoms do people have if their heart rate is slow?
Lower blood pressure.
Right. So what is and so right, so they could be tired, they could be
Fatigue.
sweaty, they
Yeah.
could feel like they're going to pass out. It's because that the lower heart rate is going to end up dropping their blood pressure, that they have those symptoms. They're not getting enough oxygen to their brain. So they're going to feel dizzy, nauseous, like they're going to pass out, or they will pass out. And in those situations, you can give them a medication to try to reverse the bradycardia by bringing their heart rate up. So this can sometimes, like, I could just give a sympathetic nervous system medication to cause the heart rate to go up. And that's what we do if the patient has a tachycardia that's caused, like a ventricular tachycardia without a pulse, or ventricular fibrillation. We do give epinephrine, and we give epinephrine when a person is in asystole, or they have no heart rhythm at all. But if you gave someone epinephrine when they were awake but just not feeling well, you'll actually bring their heart rate up significantly high. You actually just give them a reverse issue. Because that's, I've been there when that's happened. You give somebody epinephrine when they're awake, their blood or heart rate can get up to like the 200. So you're using atropine because you want to bring their heart rate up, but not too high. You just want them to feel better. You should not use atropine if the person has an obstruction of their bowel or bladder, and one of those examples is BPH, because if I'm going to slow down their bowel and bladder and they already have a problem, then I'm going to make it even harder for them to pass urine or stool, because atropine is opposite or blocks the parasympathetic response. So that means I would slow down the bowel and I would not allow the bladder muscle to contract, so they wouldn't be able to urinate. The myasthenia gravis one will make more sense when we talk about what myasthenia gravis is. And this is where things get sort of turned around, because you keep thinking of it backwards and forwards. Like if I activated the parasympathetic system, or if I blocked the parasympathetic system, if I activated the sympathetic nervous system, or if I blocked the sympathetic nervous system. So it does get confusing, but we will review it again next class too, because that's important for the exam. So now we're going to move into the part of the nervous system that's affecting your muscles. So your muscle gets information from your involuntary, but also your voluntary nervous system in order for movement to occur. Those receptors are cholinergic receptors. They're slightly different than the parasympathetic kind, but they're similar, and the same neurotransmitter is involved. It's the it's acetylcholine. So when somebody, this will be a nerve that was, and there's the synapse that was feeding a skeletal muscle. So there'll be receptors here. And the neurotransmitter that's inside the little vesicles that's been prepared is acetylcholine. And these are cholinergic receptors. If the electricity goes down, the action potential goes down, the action would be for acetylcholine to be released into the synapse, and then it would interact with those cholinergic receptors, which would cause muscle contraction. The reason it does that, and we did talk about this a little bit in the cardiac unit, is that cholinergic stimulation causes calcium to go into the muscle, which is what initiates the shortening or the contraction of the muscle. So we kind of talked about calcium's action on smooth muscle of blood vessels when we talked about calcium channel blockers, that if we block calcium entry into the smooth muscles of blood vessels, then we inhibit contraction. What was the name of the calcium channel blocker that was for blood pressure that we talked about? that you don't want to answer, but I always caution people um, that these answers should just be flying off the tip of your tongue right now because we've had the cardiovascular unit, and so you know it so well that you.
Can you repeat it again?
Yes. What medication blocks calcium from entering the smooth muscle of blood vessels? Yes, it's nifedipine. So, and there's a calcium channel blocker that's used specifically for the heart, not nifedipine. Does anyone know the other calcium channel blocker that we talked about? Oh, do you remember the calcium channel blocker we talked about that changed heart rate? We didn't talk about it as much as nifedipine. So, hydralazine is a direct muscle dilator and mainly in the blood vessels. The one that affects the heart rate is still thiazide. Um, and then aldosterone is the hormone that helps preserve blood. That's okay. I appreciate you trying because it helps to kind of keep jogging your memory about some of these other medications that we're talking about. Never feel bad if you get the wrong answer. It's more that you're trying to think about some of the stuff we talked about. So this is kind of a complicated picture, but it's really important to understand if you want to understand how medications that affect skeletal muscle work. Typically, the medications we use for skeletal muscle would be either we want to promote muscle contraction or we want to promote muscle relaxation. And so we would have to manipulate this setup if we wanted to do that. So remember that this works because the nerve stimulus comes down and acetylcholine is then released into the synapse, which then interacts with the cholinergic receptors on the muscle. And this interaction causes calcium to enter the muscle, which leads to shortening of the muscle. We get muscle contraction. So we could either add to this response if we needed, or we could block part of this response if the person needed their muscles to relax. So stimulus causes release of acetylcholine in the synapse, which binds to cholinergic receptors. And then when we want the muscle contraction to end, so this happened, now the patient or the person is done contracting their muscle, we want the muscle to relax. In order for that to happen, we have to get rid of acetylcholine. So some of that we know has reuptake, and some of it goes and leaves, but a greater portion of it is broken down by an enzyme within the synapse, and the enzyme is called cholinesterase. So those are some of our medication targets, and that's just obviously a nicer picture of how those nerves work, because it's one motor nerve with many, many offshoots to all the different muscle fibers, so that this whole muscle contraction can occur in a coordinated way. So the first disorder that we're going to talk about that you can use to treat this is myasthenia gravis. Myasthenia gravis is an autoimmune disorder that leads to the breakdown of those muscle receptors, those cholinergic receptors on the muscle. So we have our nerve and we have our muscle, and normally we have a bunch of receptors on the muscle, but now maybe we're missing every other receptor because for whatever reason our own immune system has broken down some of them. So if a nerve the stimulus comes down for muscle contraction to occur, if there's, here we are, we have our stored acetylcholine, we allow that to go into the synapse. If there's less receptors to interact with, there'll be contraction, but the contraction will be weaker and will fatigue easier. So the patient who has myasthenia gravis will complain of decreased muscle strength and easy muscle fatigue, because even though their nervous system is working and the message to increase contraction or to make a movement is occurring, the nerve works perfect, there's just not enough receptors available, and so the muscle contraction is weak and tired. So a patient may have symptoms that they notice because of this problem. It could be that if their respiratory muscles, especially the ones that we're in charge of, those accessory muscles, the muscles, some of the voluntary muscles that we use for swallowing, some of the muscles that control some of our eye movements, they just might have decreased activity tolerance. When myasthenia gravis becomes severe is when people have difficulty eating and breathing with enough strength. So obviously that's a condition that would need to be treated. So in order to treat that, in this case, we would want to enhance muscle contraction. So we want more acetylcholine. If we can't do anything about the receptors or the muscle itself, because the receptors are the ones that have been broken down by our own body, and we only have so many nerves. So what we try to do is keep acetylcholine here longer, because we know what happens, or what's supposed to happen, is that acetylcholine will get released, and then when the muscle contracts, there will be an enzyme, cholinesterase, that comes in and breaks what's left over of the acetylcholine in the synapse. But medications for myasthenia gravis will actually block cholinesterase. If we block that enzyme, then acetylcholine is allowed to stay in the synapse longer, and the end result is that our muscle contraction will be stronger and less fatigable. So we will not feel as weak. We will be able to swallow appropriately. We'll be able to take deep breaths if we need to. So this is an example of a cholinergic medication that is specifically meant to act in the synapses of skeletal muscle, but we know that no medication is completely selective. We wanted it to work there, but we know that that won't always be the case. So that's what we have to think about when we're thinking about side and adverse effects. So say the provider is wondering if the patient has myasthenia gravis. They might say, okay, I want to know, you seem to have these symptoms that suggest myasthenia gravis. I want to know if you really do. So I'm going to give you a test dose of a medication in the office to see what would happen. And that medication is listed right here. That's called endonorphium. It's a very, very short-acting IV medication that blocks cholinesterase. And if it works, if the patient actually has myasthenia gravis, then they will have a brief time that they can contract their muscles normally. They will feel the difference. Like, oh, I feel stronger, I can swallow easier, and whatever I was complaining of feels better. If that works, then you could consider long-term, long-acting treatment for the myasthenia gravis, because you know that that will help. So that's one way to diagnose it and see if the patient will benefit from the treatment. So that is often the test question that you'll see in regards to endonorphium. It's a way to tell if the patient has myasthenia gravis. So the person comes in with muscle weakness and they are given the short-acting IV endonorphium. If they have myasthenia gravis, what happens to them? How do they feel? exactly. So if they got the medication and they don't feel any different, then they may not have myasthenia gravis and they won't benefit from long-term treatment. So that's always a question, and it could be asked in either direction. If we find out that they would benefit from treatment, then that medicine is pyridostigmine, which is a medication to take by mouth, um, and it's used to affect the activity of skeletal muscles. We want only that the patient would have an increased strength of contraction of skeletal muscles. However, we know that it's not as selective, so we would have to worry about increased activation of the parasympathetic nervous system, because it's possible that we will increase available acetylcholine everywhere that acetylcholine is, not just the skeletal muscle. So that means they could have increased pupil constriction. They could have increased salivation, so like a watery mouth. They could have um, bradycardia. They could have a decrease in their blood pressure. They might have difficulty if you want their lungs to dilate because of an asthma attack. They will have an increase in urinary muscle contraction and intestinal muscle contraction. So just like we talked about before when we were talking about cholinergic medications, there are things you have to worry about. If the patient already has low heart rate and then we give them this medication, they could have a lower heart rate. That would be an issue. If they have asthma, we'd have to be cautious about giving this medication. If they already have issues urinating or moving their bowels and we give them something because of obstruction, especially, so those people with BPH, then we'd have to worry about giving them this medication because we'll make their symptoms worse. And then our reversal is atropine. So just like the cholinergic medication we talked about earlier, when we talked about bethanechol, it was specifically supposed to be parasympathetic nervous system that affected the bladder when there wasn't an obstruction, and our reversal was atropine. This situation is a skeletal muscle medication that's supposed to increase acetylcholine in the skeletal muscle space, so it's a cholinergic, but it could end up causing parasympathetic issues, and again, our reversal is atropine. Now, I mentioned before that for parasympathetic, for anticholinergic medications in general, not during overdose, we had to be careful if someone had myasthenia gravis. And that is because we don't want to block all of their movement. And I'm going to explain that more after we take a little bit of a break. So it's 1:35 right now. We will come back at 1:50 and we'll do just a little review of the adrenergic and cholinergic receptors before we finish up with muscle relaxers in general. So come back at 1:50. Try to my desktop. Keep the medications that are adrenergic, anti-adrenergic, cholinergic, and anti-cholinergic organized. So adrenergic medications we will be learning next later in the semester, and those are medications that are usually used for respiratory conditions like congestion and asthma. So it's decongestants and rescue inhaler. And so that means they're going to be like the sympathetic nervous system. So knowing that, what are the side effects? Or what will the patient potentially report? go ahead and shout stuff out.
Hard time breathing.
So if it's activating the sympathetic nervous system, then they should be, their respiratory rate might increase, but oh, can you not hear me anymore? Oh, okay. Can you hear me? So if the medication was activating the sympathetic nervous system, what responses would the body have? So it could be side effects, like what will the patient experience if their sympathetic nervous system is activated? Like what happens to the pupils? Right. So like what?
You got decreased rate of digestion, decreased blood flow to GI tract in general.
Motility. And the reason we have decreased blood flow to the GI tract and to the kidneys and to all those organs is because of vasoconstriction. Well, I can't tell if it's cutting out because I'm being quiet so that you can answer, or if it's truly cutting out.
No, when you're talking, it cuts in and out. Like when you were asking the question
Okay.
earlier, I was still like it was like in and out trying to make out what you were saying.
Oh, okay. Well, sometimes I have to hang up and try again. So I'm gonna come out and then I'm gonna hang up and then try to get back into the call.